But I just want to say to everybody, and you, Dr. Cooper, thanks for being here tonight. Yeah, Dr. Cooper is an associate professor of pathology here at Feinberg School of Medicine, and he's also our lead for computational pathology. And he focuses on computational pathology, digital imaging and AI in malignancies. And we're very excited that you'll talk about computational path. And I think it's really been evolving logarithmically, and we're going to see a lot of use here at Northwestern, and we're already seeing a lot of use in other places. So thanks again, Lee, and please go ahead.
Thanks for having me. So here's kind of an overview of what we'll talk about today. This is not going to be a urology or prostate intensive presentation. It's just going to be kind of a high level overview of this area of research and technology, and sort of providing some driving use cases with some of the projects we've had in other diseases here. So I'll talk about first whole slide imaging and digital and computational pathology, and then some of the important limitations in AI. There's a lot of buzz and hype about this technology, and I think the term intelligence can be very misleading. So I want to try to kind of create a realistic impression about what this technology can do, and how it's different from humans, and how humans and machines can complement each other. So for applications, I'll sort of show you two flavors of computational pathology analyses. One learns from patient level labels without going into the actual images and annotating structures. You just have images go in and predictions come out. And we'll talk about a model we developed to predict clinical outcomes for glioma patients. And then we'll show you a different flavor, which is more based on using the machine learning to identify and delineate structures, and then to build on top of that predictive models that are rational and designed in a very intentional way to represent biological or clinical concepts. And we'll show you an example from breast cancer. Then I also want to talk about the implementation of digital pathology at Northwestern Medicine and some of the changes that are going to be coming up, as well as our research slide scanning that we're doing. So digital path has been with us for a long time. I've started working with these images in 2005, but it's only been recently in 2017 that this was approved for use in primary diagnosis. Before that, it was essentially just use in research only. So, what these machines do is essentially consume a single glass slide and produce an image that has several billion pixels, and that's typically done in less than a minute. You see this wheel here, it's queuing because, or it's a little choppy because I'm on a slow connection. But, what happens is you get this digital image and it has multiple resolutions stored in it, and it allows the pathologists to, review these things remotely through a network connection, and to seamlessly zoom through and pan through the images, and to do their diagnosis in a digital fashion. And that creates a lot of opportunities, and we'll talk about all of those opportunities. And we're really just in sort of the early phases of diagnosis. Some of the costs associated with storage and IT have been really a big inhibitor of adoption of this technology. I'll talk a bit about that a little bit, but there are very few sites here in the U.S. That have a full digital pipeline. In Europe, it's actually quite common. So we're working in that direction. What attracted me to this field as an engineer is I think that pathology has unparalleled scale and complexity. And if you look at not just other areas of medicine, but other areas of data, it's just tremendous what the pathology lab is. It's essentially just a data factory. So we have the whole slide imaging, obviously sequencing as well. These are big changes that have happened very recently. I think there are new technologies and assays that are now used in research widely, but they will eventually find clinical adoption. So multiplex immunofluorescence and single cell sequencing, and so the data is only going to get larger and more complex. And I think one of the things that's really enabling us to use and leverage this data, although not fast enough, is that every year the cost of storage is decreasing, and it's pretty precipitous. It just keeps going down and down. So we can store an equivalent area, an equivalent number of images in a smaller physical space due to increases in density, and it's cheaper to do that. And so I'm very optimistic that even though it's maybe a stretch now, 5 years from now, 10 years from now, the storage is not going to be such a limiting factor. So what are the opportunities? I think everybody's familiar with the inter-observer variability problem and pathology and the reproducibility issue. And so the application of the criteria is subjective. In doing diagnosis, if we can make that, reproducible and objective, we can improve diagnosis for patients. You can also reduce noise in clinical research and clinical trials, which I think is a big problem. Not only are the rules applied subjectively, they're based on, subjective measurements. And so I think another thing we can do is to start using, quantitative image analysis tools to make reproducible measurements and to build, more objective, criteria using those reproducible measurements that are quantitative. So I think that's another exciting opportunity. I think maybe that's where we'll see some of the first advances outside of the sort of, simple applications like cancer diagnosis, but looking at things like prognosis. Instead of having the model generate the prognosis, we'll be using, quantitative measurements to develop new prognostic criteria. There's obviously an issue with subspecialty expertise and access in places, even within the rural U.S., but other countries as well. And so one of the hopes I think for this technology is that it could take general pathologists and allow them to do more work, but to also operate at the level of subspecialists in many cases. And so that's sort of the value proposition for some of these tools, is that not that they improve on someone like Dr. Yang, but that you can take someone who works at a community hospital and make them perform more like Dr. Yang and doing a Gleason scoring or something like that. So I think another thing we think about is how can we make histology analysis just like another tool that's used routinely in research labs, just like genomics, where it's almost like a service or a commodity. And I think we'll get there eventually. We have a long way to go, but hopefully we can sort of introduce another omics category of histology omics. I think that would be really exciting. So, it took a while, but AI is actually here now. So, I'm sure all of you know that this company, Page, that spun out of Memorial Sloan Kettering, they have the first ever FDA-approved product for digital pathology. And so this is just essentially doing cancer detection. It's, it's not a trivial problem, but I think it's not as complex as, problems like prognosis. But, if you believe the studies, these things supposedly really improve precision and recall for pathologists who are doing cancer detection, and I think we'll see how this all works out in the near future when people start using this. So that's very exciting. Google has done a lot of work looking at Gleason grading as a problem and have published a lot of papers there and studies. And so they are partnering, Google Verily is partnering with a digital path company to try to sort of market some of these products. And there, like I said, I think the value proposition is that you can have general pathologists do very accurate Gleason grading. So there are different paradigms for clinical use of this technology. One is a first read or a screening where the algorithm will look at the cases as they come in and decide whether or not a human needs to look at it. And so in this paradigm, there will be a lot of cases that the algorithm feels like it can confidently classify, and it will set those aside and they will never be reviewed by a human. So this is a way to get efficiency gains. There is some increase in risk with this mode of operation. There's also what's called a second read, which focuses more on increasing quality and less on efficiency. So the idea here is that the pathology and the computer both do a read, and there's a system that identifies and flags contradictions for review. And so, you can, increase safety this way, but there are no efficiency gains in this mode. And then there's the assisted read, which is kind of like humans and machines working together. So you can think of this as like, if you had a toolkit that could do like, identifying mitoses and counting mitoses or scoring immunohistochemistry. So, the pathologist's desktop would have, all these different applications, and they could apply these tools and then interpret all that information to make their judgments. And so I think, this is something that we work on quite a lot, because you can kind of identify nice sub-problems and, break them off and attack them. So that's the assisted read. When we talk about the computational paradigms, there are really two that we think of. The first is, probably familiar to people. We would call this feature engineering. Even if you haven't heard this term before, you've probably seen this concept. So the idea is the machine learning would be used to identify, classify, detect, and delineate structures in the tissue. And so you would take an image and you would map out all of the structures and identify them and classify them. And then from that, you can calculate things like, what is the degree of lymphocytic infiltration, or, what is the interaction, between the, lymphocytes and the tumor, or what does the stroma look like? And you can generate like very, interesting measurements, that you can design and capture in a quantitative way from these images. And so there's a company called PathAI that is also, I think, well known. And they have more of an approach like this, where they pay an army of pathologists to generate the annotations, and then they train the computers to do it automatically. And then they have, an array of measurements they can make, from the specimen, and they can use those to build prognostic models, or, to provide, tools for someone who's reading a case. So another paradigm is what we would call learning from patient level labels. And so in this paradigm, you have an annotation that corresponds to the entire slide or to the patient. And what you would do in this case is, you would learn directly from the pixels to predict those, those labels. So it could be a diagnosis of cancer, or it could be a molecular biomarker, and you would develop algorithms to predict those things just directly from the images themselves with no intermediate annotation of the structures. So, there's the Page prostate tool works like that. They were able to take the Memorial Sloan Kettering archive and not do any image annotation, and just use the existing, diagnoses, which are in the medical record and structured, and just do a big machine learning problem with that without having to mark up any images. So that's very appealing. It has some limitations. In this approach, sometimes you can't really understand what the machine is thinking. You can maybe understand the areas of the image it's focusing on, but you don't really know precisely what it's measuring. So in some sense, it's kind of a black box. There's a lot of popular work right now in trying to predict, genetic alterations from H&E. And so the idea here is that you could sort of pre-screen people and rule people out, and then apply sequencing to the others. And, it doesn't really give you like a good enough, prediction of, say like a variant to be able to replace the genomics, but it does, give you a lot of value for, $4 H&E and some computation. So that's, I think, an interesting approach. It also uses this sort of patient level learning type of algorithm. So, some of these things seem pretty amazing. I think, an advantage of being an engineer is you sort of understand these machines in a different way. And so I always like when I talk about these things to point out to people that, although this may look like intelligence, it's really not anywhere near, human intelligence, which is very remarkable. So, as an example, you can take an image that looks like a pig. And if you have, one of these algorithms that just classifies, the entire universe of images, it will reliably predict that it's a pig. You can take that image and you can add some small imperceptible amount of noise, shown here is like static, and you get the image on the right. And now, the algorithm thinks this is an airliner. And, this is a real study that was done. They showed that, just small amounts of noise can completely confuse these algorithms. And this is not a mistake that a human being would ever make. And so what's happening here is that, these algorithms are essentially unable to extrapolate at all, right? Which is something that, humans are actually quite good at. So, you have your training data, you have a region of your sort of input space where your training data is defined. The algorithm works in that area. You have some guarantees of performance. You can measure and characterize that. But once you go outside of that area, you're going to have problems. You might be accurate, but you don't really know. Nothing is guaranteed. And so, in pathology, because of the tissue processing, we use a lot of very noisy mechanical and chemical processes. There's a lot of pre-analytical variability, which leads to, extrapolation. So the quality of the images change, the colors change, and then, all of a sudden, the algorithms stop working. And so that's really, I think, what we're contending with now and what's causing a lot of failure of these technologies. They look great in one data set, you apply them in another scenario, and they completely break down. So, when you hear people talk about AI or machine learning, I think it's better to sort of think of this as curve fitting, because it really does behave very much like curve fitting. There's no real intelligence. There's certainly no understanding of causality inside these machines or algorithms. They're just, fitting curves, but instead of fitting curves to, Excel spreadsheet, they're fitting curves to images, which is pretty amazing, but, it still has those limitations of curve fitting. So, really the secret to, making these algorithms good is to have a very large amount of data. And so, some of the things that are challenging to get in large volume are things like annotations of images from, pathologists. Clinical outcomes, I think, can be, very difficult to acquire, in large volumes. I think slide scanning is getting easier and easier, but it's sort of the other data that I think limits us many times. Another thing about this fact about, big data being so important is that problems that are relatively rare, where it's hard to generate an abundant number of examples, something like a rare diagnosis or a rare histological subtype, that's going to be really hard to deal with. And, but those things happen, obviously in practice. And so, that's a place where I think, algorithms are going to have a lot of problems. But all of these things that are sort of weaknesses for algorithms, people tend to be very good at. Pathologists can recognize when they're seeing something that's extremely rare. Maybe they haven't seen it before, maybe they've only read about it, but they can sort of, figure that out using, their recall. And so it's a very different type of intelligence that humans have. So no, we're not going to be replacing humans, which I think is reassuring. So let's talk about these sort of feature engineering approaches first, looking at this breast cancer problem. So we have a student who is interested in machine learning, but he's also very interested in breast cancer biology. And so his entire PhD, he really set out to develop algorithms that could describe the tumor microenvironment and all of the components and interactions that you would find, in a breast cancer slide. And looking at things like, what's happening in stroma, what's happening with the epithelium, and, what are the immune cells doing. And so he set about to, build this model in a way that would allow him to ask specific questions and, investigate these topics. And so what this started off as was, we generated a team of medical students all over the world, and pathology residents and pathologists, and we asked them to come and join us and annotate data. And so we came up with a protocol that allows us to assign hard cases to pathologists, easy cases to medical students, and then to have the residents and the pathologists review everything. And so we were able to generate, about over 200,000 annotations of cells and tissue regions. And then what that allows us to do once we have that data is to, train algorithms to do this task very reliably. So I won't get into this. I mean, there's just a lot of boring technical details about how this is done, but it was successful. We released these data to the public. This is the largest data set of breast cancer annotations that exists currently, and it's used in a lot of benchmarking procedures. So, what allows us to do this is that we have this platform we've developed with funding from the NCI with my colleagues from Kitware and Emory University. And this is essentially a centralized server that hosts the digital pathology data, and it allows us to, work with people who have just a web browser to view and annotate images. So we store these on, Amazon or on our local server, and then people, log in remotely and can work with the images and annotate them, and we can also kind of see what's going on and keep track of the study. And this just really makes the logistics of doing these annotation studies much easier. So this tool is open source. We've, I think, invested over $4 million in this. It was recently picked up by NVIDIA. They're using it in one of their pathology AI tool development projects. So we're very excited about that. We hope that, with their support and funding, this will continue to improve as a tool. So, once we had all this data, we were able to build models that do this annotation automatically. And so what I'm showing on the left is just part of a whole slide image where the tumor is shown in dark pink, the stroma is shown in light pink, and then, the immune infiltrates are shown in shades of blue. And so at every pixel, we classify the tissue region, and then we classify and delineate individual cell nuclei. And so we get this really rich map of, essentially what's going on in the tumor, and it's very accurate. We don't have a lot of specimens that have normal tissue on them, and so that part is not very good. But when we're looking at highly rich tumor slide, we have very good accuracy in mapping out all these components. So from these maps, we can generate quantitative features that look at things like how are the lymphocytes aggregating, what is their proximity to the tumor, are they in among the tumor nests, are they outside, what is the morphology of fibroblasts that are adjacent to areas of tumor, all kinds of features that we can measure that look at characterizing things like collagen and maybe things that might inhibit invasiveness of the cancer. And each one of these measurements can be designed with a specific intent or purpose, and so that allows us to have a model that's interpretable, but also to sort of test hypotheses about prognosis, which is, I think, exciting. So we came up with a computational grading scheme, and we compared this to the manual Nottingham grading. This was done in a data set from the American Cancer Society. It's a big cohort study they have of 1,700 breast cancers. And so, we see that when we build models using grade and IHC scoring, and compare with Nottingham grade and computational grade, we get a much better separation using these computational measurements. If we look specifically, for example, in Nottingham grade 3, and we try to reassign these patients, we can see that we can take patients that have an outcome more consistent with grade 1 and identify those and separate those out. So even within these Nottingham grades, we can really separate out people that look similar to the pathologist but have very different outcomes. And I think we're very excited about that as a result. When we build these models, we have weights for the different variables that go into these predictions. This print is very small. I won't go into details, but we have different groups of features that correspond to things like immune or stroma or epithelium. And so we have those color coded, and we can see what are the sort of positive and negative predictors. When we look at the scoring we use to generate these prognostic groups, they're predictive of outcome independent of other factors like stage or screening in breast cancer. So this work is ongoing. We're validating this in a study called the PLCO, which has a very large breast cancer cohort. So that work is ongoing. Okay, let's talk next about more of this patient-level learning approach. And this was some work that we did back in 2017, looking at how we can learn clinical outcomes directly from images. And so we took a model that's usually used for image classification, and we did a little bit of mathematics, and we were able to marry that with a regular Cox regression model that you would use for biostatistical analysis. So it's essentially a biostat survival model, but it can read images and predict outcomes. We built a model that can consume both H&E as well as some genetic biomarkers, and we compared this with human grading and also human grading plus biomarkers, and we showed that this machine is able to grade gliomas essentially as well as humans in this TCGA data set. And this is without really doing any description of the scene or annotation of these images. So, this model is somewhat of a black box, but what we can do is to use it to sort of paint the entire slide with colors that indicate, areas that correspond to high-risk patterns or low-risk patterns. And when you do this, you see some interesting structures that are identified as high risk. that are consistent with the grading criteria used by pathologists. So the model is able to learn to recognize these microvascular proliferations, which are definitional for grade 4 glioblastoma, and it's able to highlight them very specifically without us telling you anything about what a blood vessel is or what these structures are. It just looks at pixels and outcomes and learns these patterns on its own. So this was some validation that I think was very interesting. We also found that the model tends to look at edema and associate that with worse outcomes. But you don't really, it's looking at these edematous regions and it's saying these are high risk, but you don't really know what it's thinking. So there's a possibility that it may be confusing this edema with necrosis, for example, or with other structures. We just don't really know. So this is an interesting result, but it's you can't really say what the machine is thinking. You can only say where it's looking when you're using this paradigm. Anything that we can do with images, we can also do with genomics. So a lot of these survival modeling techniques, we first evaluate them using like gene expression data. And so we can take gene expression profiles and we can try to learn from these to predict outcomes and do things like identify pathways that are enriched with important gene expression variables. And so this is something that is also ongoing, but pretty much any of the data that's generated in pathology, we can apply machine learning models to those. So this is a study we did with our chair, Dr. Bratt, where we looked at oligodendrogliomas and found that these Notch and PI3 kinase pathways were really focused on by these machine learning models and learning to predict outcomes. Okay, so let's change gears here now and talk about what's going on at Northwestern Medicine with digital pathology and some of our implementation projects that we're doing. So our end goal is to do primary digital diagnosis and full digital archiving. So we would scan every slide that's generated here, and most people would be doing digital diagnosis, although it's up to the pathologists. So this is a very big, massive project. We're talking about completely transforming the pathology department with this. And so we're doing this in a phased rollout. So phase 1 is using digital path and tumor boards and consultations across Northwestern Medicine and in some of our quality initiatives. We have completed phase 1 and it's working quite well. We're bringing some of the other tumor boards online, but we already have quite a few tumor boards that are using this. So the next step then is really integrating the digital scanners with the rest of the lab information system, which allows us to essentially really scale up the scanning that we do. And it also allows the pathologists to view images from their diagnostic tools. So they have a portal with Beaker, and then they can just essentially open a case and launch the slide viewer from there. So that's going to be really essentially setting the stage for doing things like consultations, which is where we'll probably recover some of the costs of doing this. And it sets us up for primary diagnosis, which is really the ultimate goal here. So that will be phase 3. We don't have a timeline for when that's starting. Phase 2 is already underway. But hopefully within some limited areas, maybe prostate cancer, we'll start doing primary diagnosis with digital. We have scanners at 6 of our medical labs. We have high throughput scanners at NMH and CDH. We have low throughput scanners at Del Norte, Kishwaukee, Lake Forest, and McHenry. All of this is orchestrated from servers that are hosted at Northwestern downtown here. And so this is kind of like a hub and spoke model. For the research, we also have a slide scanner. It's integrated with the clinical lab, which has a lot of advantages that allows us to intercept slides and do prospective studies. It's really the way that we wanted to set this up so that it's right there with the histology and with the other slide scanning that's going on. So we have one of these high throughput scanners that's dedicated for research. We have an IRB approval for prospective scanning of cancer cases and developing a database around these. This uses a consent waiver to allow us to do this. And the current work that we have ongoing here is automating some of the steps that happen after the scan happens. So extracting information from the slide label, linking this to other data from the clinical record, and producing de-identified data sets that are very easy for our trainees to work with. We're working with NM on an anatomic pathology data mart. This will allow us to get structured data that's going to be very, very useful for describing what's in these slides. And that's, I think, going to give us like a really big advantage in this area, is being able to scan at volume and then to have this structured data at our fingertips. And then all of this will be integrated through the platform I mentioned before and using a REDCap database. So, Dr. Ross and Dr. Yang and myself have already started working on scanning cases. We just really scaled this up recently. We're scanning entire cases of HOLEP and positive biopsies. We've scanned in a very short time 3,800 slides. And we have a postdoctoral fellow coming in this summer who's very excited to work with this data. He's a very interesting guy. He likes to participate in these challenges, and he's very competitive and has won quite a few of these challenges based on prediction from images. So I think the future looks good for working with prostate cancer here in Digital Path. Okay, that's a bit short, but I wanted to make sure we have enough time for discussion. I'm just going to leave you with a few thoughts. So we talked about these clinical and computational paradigms, and so when we start these projects, we're always thinking about how is the pathologist going to use this, and how are we going to design those algorithms? And so it always comes down to sort of that choice of first read, second read, assisted read, and driven by annotation or patient level learning. So those are the questions that we need to answer early when we start these projects. Really, the key ingredient for success here is actually not technical machine learning knowledge. It's having data. It's having a lot of data and having that linked to the right variables and having everything readily usable. So much of our work now is focused on how can we really eliminate bottlenecks and build high quality large data sets that will allow us to get the best results and write the best papers. And then also developing strategic collaborations with other institutes where we can validate our algorithm on their data, or they could validate their algorithm on our data, and how we can do that in a way that doesn't take tons of negotiation and administrative overhead. So we're building these data sets. We can scan roughly 1,000 slides of research a day, and we're putting together these data pipelines. And I think we'll be happy to update you all again in the future about that. Just wanted to acknowledge some of our trainees. We get funding from a lot of sources. One of the challenges is working in different areas of cancer is learning a little bit about everything. So we have funding from the NIDDK, from National Library of Medicine, National Cancer Institute, the NINS, and we also work with industry quite a bit. So be happy to take your questions. Thank you.
Thanks, Dr. Cooper. That was great. A couple questions. One is, I was impressed by, you had run the publication when it came out for the PANDA project that was basically doing the Gleason grading. And, obviously, like you said, the idea is not to try to make great pathologists better, but to kind of help elevate things. I don't know how much you can prognosticate about this, but I know that Northwestern will be online soon, like as you mentioned, getting all of our things digitally scanned. How much are we going to run some of these algorithms in the background in our day-to-day clinical work so that we can sort of get auto-validation? And if they're trying to plug that into the rest of how we use the EDW, which is our electronic data warehouse of EMR, so we can sort of, feed forward almost in the background as we go through. And I think this, but almost all of our staging right now has a synoptic reporting that pathology does. And so those are all queryable fields. And so you could imagine it just happening in the background over a year, and the year finishes and we've got, whatever, like 40,000 pathology cases. Do you know anything about how that's going to work, or any thoughts?
Yeah, I mean, it's really all about, automating those steps after the scanning, to get that data set. And, I think we know how to do that. It's just a matter of putting the work in and validating. And if we're doing this prospectively, we have a big advantage in that the new slides all have barcodes, and so we can read that barcode and then talk to the pathology data mart that's coming online soon, and then do all that linking and pull all that structured data in. So the goal would be to get this to the point where the actual scanning of the slides is the bulk of the work, even though that's very easy. Once we have the algorithms, one thing I would say is I think this platform we've developed that allows people to interact with the images and to invoke algorithms or to look at algorithms. I think that's an area where we're actually ahead of industry in being able to integrate those algorithms and visualize their outputs. And so I think we'll be able to do some interesting work where we're scanning slides as they come out of histology and then evaluating these algorithms prospectively with that platform.
Great, thank you.
For those of you who attended GU ASCO, there was a really interesting presentation by a group from UCSF where they took a few thousand slides for patients who were followed on some landmark R2G trials like 9202, 9408, 9910. And they essentially were able just to look at these old slides, just biopsy slides for patients getting radiotherapy plus or minus hormonal therapy or dose escalation. And just by doing an AI analysis of those slides, on top of NCCN and a few clinical features, they could predict distant metastases like with an AUC under, I think, or around 0.85. And I think, just going through this wonderful talk, by the way, just seeing what is possible, I think this could be a very sort of interesting avenue for research. I'd love to actually chat with you offline, Dr. Cooper. I think we could engage in some very similar efforts.
And Dr. Sachdev, Ted and I have been linked in with Artera in that group, and actually we're collaborating with Dr. Cooper with them as well. We've been looking at it at validating some of the scores in our surgical series, and we're just starting to lay the groundwork for it. But I think they really need prospective validation in the rad-onc realm as well. And certainly chat with Dr. Cooper, but they're going to come down here for Big ASCO, and we're meeting with them probably while they're down here, and I'll certainly rope you into that as well. So please, Dr. Cooper, say what you wish, and Dr. Sachdev is an excellent collaborator, and I think bringing you into what we're doing with them would be phenomenal. So I'd love to do that, John, also.
That sounds great. Thanks, Ash.
Yeah, I think when we talk about predicting things like metastasis that are, pathologists, they don't really think about doing that. I mean, they are predicting correlated variables, but it'd be very interesting to see if those algorithms are accurate, what patterns they're looking at, and really do a disciplined analysis with the pathologists to see if they can, maybe learn how to detect some of these things themselves, or maybe they're patterns they already appreciate and they just don't attribute them to, metastatic potential.
Anyways, if there's no more questions, thanks again, Dr. Cooper, for being here. Thanks everyone for their attention, and everyone can have a great evening. I think we have our next talk next month. Dr. Sachdev, we certainly, Cooper's been helping us with a ton of prostate cancer projects that we're just launching, so we'll definitely get you linked in with us. I think there's a lot of exciting things to do, and thank you all for your attention, and thanks, Dr. Cooper, for being here.
Thank you all. Good evening.